Okay, hello everyone. My name's Goodyear. I'm the Exec Director for Acute Services at St Vincent's, and I'm delighted to be here today to share with you all some of the work we've been doing at St Vincent's Hospital Melbourne. In particular, some of our winter initiatives that we employed this year. We entitled the presentation Avoiding the Winter Blues, and hopefully we can share with you the St Vincent's story in regards to how we avoided some of the winter blues this year and how hopefully we'll avoid them in the future. I'm going to be co-presenting today, so I'm also be presenting with Jacqui Bilo, who's our General Manager for Medical and Emergency Services. I've only been at St V's for the last 5 months, and she was actually the brains trust and coordinated a lot of planning pre-winter, and so we're going to co-present today. So at St Vincent's, I guess what we did from the start, obviously pre-winter, is formed a bit of a coalition of the willing, and but what we really tried to focus on was a whole of hospital approach to our winter strategies this year. So we formed a multidisciplinary team. We brought together our key clinicians. Some of the secrets to improving flow in ED is not in the ED, as everybody would know. It really requires a whole of hospital response to support all of our patient access. And so we formed a key team of key clinicians, our senior managers, nurse unit managers, and key stakeholders across the organisation. And what we brought together the team to brainstorm the ideas. And really from that idea generation came our action plan, and some of which we'll overview today. We did get some funding, and thanks to the department for that. I think most health services got a bit of extra funding support in the lead up to the end of the financial year and in Q1 this year. So we did get some funding support for the initiatives that we're going to talk about today. However, each initiative we really focused on sustainability and really thinking about how we can continue all of the initiatives beyond winter. I think when we look at demand for health services, it's hard to actually find the pattern of winter. We know health service demand is just continuing to grow year on year, and really the winter blip is very small when it comes to the overall growth year on year. So our group, I guess our team at St V's, we prioritised and really established our key initiatives. We developed the implementation plan, and then we really monitored that quite closely, and the team were really meeting fortnightly, in particular in the planning phases. And then over time, obviously, we monitored how we went throughout over winter. The key initiatives we're going to highlight today, so they include our daily management system and our problem-solving approach and problem-solving methodology, which really has been fundamental to the improvement that's been going on at St Vincent's. We're going to highlight some of our emergency care initiatives. We trialled a 5th medical unit, so we have 4 units in normal business in general medicine at St V's. We added another 5th medical unit as a dedicated winter strategy. We also implemented some rapid flu testing. We'll tell you a bit more about that. We've also had a big focus at St Vincent's on length of stay in acute and subacute, and we'll talk to you about some of the results of that and how we've been managing our bed plan and really trying to improve our efficient bed utilisation. And we also did a work on nursing workforce strategy, and we'll talk to you about some of the highlights of what we've been able to do in that space and some of the work that we're still working on to support our nursing workforce. So our daily management system. Really our daily management system has been the key foundational initiative, and really what it is about cultural change at St V's, about seeing the problems. So really what we're trying to do with the daily management system is bringing up the problems and empowering local teams with a standardised problem-solving approach to help them or to enable them to solve some of their own problems. Where they've got issues or where they've got challenges that they can't resolve on their own, what the daily management system does is provide that more senior support to overcome some of the barriers that maybe the local teams are experiencing. And so our daily management system starts with Tier 1. So Tier 1 is the local multidisciplinary team. So it might be a ward-based team, consists of the ANUM on for the day, with the junior doctors and the allied health. And they'll talk through how they're tracking for the day, what are some of the issues and challenges. And the great thing about this system, it's not just about patient access, it's about safety and quality, It's about our people and resources, which all, as we know, come together to actually help our activity and our performance of hospitals. So at St Vincent's, it's been, I guess, our daily management system's been a couple of year journey. It's gone live. Our daily management system went live across all wards at the start of this year. And you can see the tier 1s there. And so the tier 1's linked to the tier 2. So where issues can't be resolved by the frontline teams at the tier 1 level, there's a general manager or senior manager that attends each of the tier 1 meetings, and then they come together a bit later in the morning to attend what we call our tier 2 meeting. And those issues that can't be resolved locally get escalated to the tier 2, where all of our senior managers attend, and our executive, in particular our clinical executives and our continuous improvement executive director. And so we're really focused there about supporting our local teams and supporting a collaborative approach to problem solving and dealing with our issues. Each local team has a weekly review, and so each ward in particular has a knowing how they're doing board, and that's where weekly there's a weekly huddle, and the team will huddle around the knowing how you're doing board and talk about the issues for the week, and also look at how they're tracking with performance. The tier 2, so we have a daily tier 2 meeting, where I said where we deal with some of our problems. That comes together weekly at what we call our tier 3 or our performance board meeting. And that's where we actually systematically go through how we're tracking with our delivery, our access performance, with our safety and quality, with our people, and with our cost. And so we meet and we huddle. So there's about 30 or 35 people that huddle in what we call our performance board area. And the team huddle, and we go through all of our KPIs and how we're tracking. And the CEO attends that every week, with all of the executive, all our senior managers, our senior clinicians, and many of the local teams attend that meeting. And that's really a key forum where we come together and we talk about how we're tracking in terms of performance. We celebrate success. We talk about some of the challenges and try to work together to deal with those. I guess some of the emergency care initiatives that we implemented this year at St V's. So I guess the ones where we've highlighted in red, we did get some additional funding from the department to support those, and as I mentioned before, we've been really focused on sustainability, and so some of those we've been working on sustaining. But to give you a general overview of what we did around emergency care, we implemented extended hours of medical coverage in the emergency department, and in particular, we implemented a rapid access team, so led by a dedicated ED physician with a registrar and an additional nurse to support our rapid assessment team. And really, that was about senior clinical decision making early on in the patient's journey after they arrive at ED, but also enabled an enhanced streaming of patients through the ED, so through our fast track area, and in particular through short stay. And we've seen our short stay activity and short stay volume increase over the winter months, and it's continued to increase since winter. We've also got a dedicated AV triage nurse in the afternoon who really has a dedicated focus on ambulance offload and really trying to improve the journey for ambulance patients coming to our ED. We'll talk to you a little bit about our introduction of the influenza-like illness pathway, and really that pathway has assisted us to reduce unnecessary diagnostics in ED, but in particular definitive or enabled definitive decision making in regards to patients who are presenting to ED with flu-like symptoms. One of our funded strategies, which really complemented our overall bed plan, was for winter we opened 12 additional beds, and actually through some of the improvement we've seen at St V's, we didn't need them some of the time, and so whilst we had them funded, we actually didn't operate them all of winter, but they obviously supported our capacity, and in particular ED admissions, and also trying to maintain that balance between providing elective surgery and supporting the emergency department access. Our ED support services, so our porters that work in our ED, we did a review of the rosters. We did actually implement a little bit additional hours, in particular to support the patient movement around ED. We've been able to sustain that beyond winter, and that's now BAU. We've had a key focus at St Vincent's around length of stay. One of the key initiatives has been our countdown to discharge. So from day one of admission, we're counting down to a designated discharge date, and the whole team are behind that, and there's a combined focus around that. And so we're actually rolling that out across our acute and subacute wards at the moment. It's been a big focus on acute to subacute flow. As I mentioned earlier, we've made significant gains in length of stay in subacute, and that's really enabled our access to subacute to improve, which coupled with that, we've been able to improve our acute length of stay. We also had a focus on pre and post emergency surgery, so times for patients waiting for emergency surgery, and also post-operatively making sure that we minimise length of stay as much as possible. We did a lot of work from our ED to inpatient medical model, and we've actually got a dedicated continuous improvement physician who's working in particular with our key clinical leaders to engage them around how we can improve patients moving out of ED. We are in the middle of that project at the moment. We'll be implementing with the new medical year in February a more standardised process with the way the ED journey works out of ED. So the way the ED refer patients to inpatient units for admission, and I guess a standardised process for patients to leave the ED and go up to our inpatient wards. One of our key initiatives for winter, as I mentioned earlier, is we implemented the 5th medical unit, and Jacqui will tell you a little bit more about that in a moment. And really, obviously, in prior years we've had significant general medicine demand, and you'll see some of the results from that, I think, on the next slide. And we also tried to implement a bit of a flexible approach to allied health, and allied health responding to referrals. So where we saw peaks in allied health referrals, we implemented a more flexible model where disciplines had a much more flexible approach to responding to increased referrals, and a bit more communication across discipline where we were seeing peaks and troughs in allied health referral demand. So I guess those are some of the key overview of some of our emergency care initiatives, and I'll hand on to Jacqui to take us through some more of the detail of some of those initiatives. Thank you.
Thank you. I should just start by saying apologies in advance. I've got this dreadful cough at the moment that I'm trying to shake off, so I'm sorry if I start to cough in the middle of my talk. So as Cameron said, I'll go into a bit more detail around some of the strategies that we've implemented at St Vincent's Hospital. One being the trial of a 5th general medicine medical unit. Obviously, this is in recognition of the fact that we see in general about 20 to 30% increase in activity through Gen Med during the winter period. So this was our strategy to try and offer additional support to our medical staff. And also, as most other organisations will know, middle of winter is when we have the physician exams happening too. So end of July, early August often creates a bit of an issue for us with medical registrars busy preparing for their exams, and consultants also have got quite a bit of workload around mentoring and educational preparations. So the 5th Gen Med unit is basically just having another, obviously extra medical unit, consultant-led, supported by a registrar or an intern, depending on what we could get over the short period of time to recruit this strategy. But for the team, anecdotally, the response has been that, we've had a more responsive time to treatment, decision making, discharge planning, also obviously help with evening out the workload across the general medical group. And in turn, obviously, we've seen a more efficient flow, patient flow of Gen Med patients across the acute services. So as a result of that, a couple of the graphs there indicates just the outcome of this strategy. So in terms of our average length of stay for general medicine, we saw a reduction of 1.2 days compared to same quarter last year. And in terms of our average occupancy for Gen Med, we also saw a reduction of 25%. The other thing that we really wanted to invest in is a much improved equipment around the PCR rapid flu testing. We know that last year we struggled with the amount of patients presenting to the emergency department with flu-like symptoms, and our ability to respond and make sure that we had early access to diagnostics was very challenging. So this year we used some of the funding that we got from the department to actually invest in a much better equipment called a Gene Expert Infinity, which really for us it meant that our rapid flu testing was much improved. We saw an increase in our turnaround time for test results to be available, overall improvement of 2.63 hours, and during business hours 3.29 hours. So it's quite a significant improvement. Just thinking of your northern turnaround time of 24 hours, so that's quite a much better turnaround time test for us. So obviously, as we've already heard, the challenges over winter is around managing our infectious patients, noting that we've got very limited access to single rooms in the hospital. So this allowed us to obviously instigate early treatment for a patient and better flow of these patients. Also, we've had some, unfortunately, outbreaks of flu in the organisation. We've been able to do a lot more of these rapid flu testing. I think, some days we're able to do up to 100 rapid flu tests in one day with those sort of turnaround times. Whereas last year we were probably averaging, maybe up to 30 a day. So it's quite a significant improvement. So in terms of just some of the outcomes, obviously in terms of our NEAT Q1 results, we've been able to sustain, as you can see there in the last 3 years. We've come from a very low NEAT base to, Q1 this year. We've been able to continually improve that, and we maintained a result of 74%, and that's in the context of an 8% increase in presentation in 18-19. So we're pretty proud of that. The other thing that's obviously we've been able to do is a sustained improvement in our average length of stay. And as you can see there, since the second half of 17-18, and if we look at Q1 compared to 16-17, we've seen a 5.6 improvement in our average length of stay as well. So as Cameron already touched on, we had a lot of focus on improving our length of stay through the DMS rollout, which you've heard about, the countdown to discharge. We also did some work with our nephrology team around day of discharge for our dialysis patients, because in the past there's fears that we can't discharge patients just in case they fail their last dialysis run of dialysis and they need to be readmitted back, and we said no, well actually that's not the case. So we've got the team's trust to actually discharge patient, have their dialysis and free up that bed for the next patient. Again, through the DMS, we talk about stranded patients and escalating those. If there's barriers to access to diagnostics, for example, that might be a barrier to discharge. As Cameron said, we have our support services staff also included in those DMS meetings so that they can actually prioritise our diagnostics, access to diagnostics for patients that are requiring discharge on the day. Obviously that helps with improved flow as well. The other piece of work that we continually work on every year and refine is around our acute to subacute flow, and so obviously that's assisted, all those strategies has assisted us to manage the increase in activity. So in terms of results for acute, Q1 this year we used 30 less acute beds than prior year and 10 beds full year, accommodating more separations. Separations increased by 9% compared to Q1 last year, and that's up to about 1,331 patients. Mental health used 3 less beds, accommodating 106 more separations this year compared to last year. GEM were able to also decrease their occupancy by 4 beds, again accommodating more separations, and similarly with rehab. Obviously, having these efficiency through our length of stay and flow means that we could better utilise a more reliable workforce, and we're not relying so much on agency staff to support our activity in the hospital. So the next graph just shows you the agency FTE. So the orange bar graph indicates this year's actuals compared to the blue line, which is last year. So in terms of agency FTE, you can see there that month on month we've been able to sustain an improved reduction in agency FTE and obviously cost around agency staffing. The key drivers to the success around improving this is around, we've put a lot of emphasis on focusing on our recruitment strategies, making sure everyone, as soon as they are aware of any recruitment or forecasting around staff turnaround, that we start to talk about earlier recruitment. We've clarified also in terms of HR support versus the manager roles and responsibility around recruitment, that's quite clear in terms of who's responsible for doing what, so that didn't delay our recruitment process. Retention of the graduate nurses, again, that's something that we do ongoing. We try to strengthen that. We have a junior nurse workforce recruitment strategy, and that's about making sure that all our graduate nurses and all our post-grad professional development nurses we're able to retain within the organisation. We've also increased appointment to the nurse pool. So I think most organisations have a pool of permanent part-time nurses that we can deploy to clinical areas where the needs are. We've struggled a little bit to maintain our target in terms of the FTE, but this year we've actually implemented a new program to support these nurses get back into the acute setting by providing more supernumerary time and educational support, and also maintaining the number of nurse bank on board. The other one is around, so during this period where we do retain more of our junior nursing workforce, we do sometimes find that we've got surplus staff, and it's about making sure that we utilise those surplus staff effectively by either allowing staff to have more leave during that period. So during the Christmas, January low activity period, we're able to release more staff to have rest and relaxation time. And obviously, again, to minimise use of supplementary staff, bank and agency, we're able to redeploy staff to the areas where they're required. We've also had a lot of focus on making sure we reduce our utilisation of agency nurse for patients who are requiring additional resourcing to manage, so specially. We have introduced a increased observation room where we cohort these patients and have a team of a nurse and a health assistant in nursing to manage them. So rather than having potentially 4 patients being specialed one-to-one, we're able to put them into this increased observation room with 2 staffing. We've also looked at a targeted improvement, recruitment and retention strategy, in particular in ICU and mental health, where we know we've struggled in the past to maintain our baseline staffing in those areas. And Cameron was able to help us also negotiate with the private around use of our ICU nurses across the public and the private. So that was a good initiative this year. And also we've implemented a health assistant in nursing bank available to the clinical areas, again for those specialing requirements or increased acuity, just need a little bit more help on the wards for the nurses. So in terms of next steps, similar to other organisations, I'm sure it's around sustaining all these improvement work that we've done and building on these so that we're winter ready next year and beyond. We're on a continuous improvement journey, which is continuing. And as Cameron said, we feel very reassured that we're in a good place in terms of the support structure that we've got in the organisation and our problem-solving methodology and approach, which we're deploying org-wide to all levels of staff in the hospital. The ED to Ward project, which Cameron spoke about in terms of having our physician-led project around how we better pull patients out of the emergency department rather than ED, constantly battling to push patients up to the next care pathway. And obviously new innovation, looking at other ways to support our increasing hospital presentations, whether it be diversion or community distribution. And key message is obviously making sure that we start early or don't stop really. It's a continuous cycle that we need to make sure is at the forefront of our thinking. So thank you.